Hello and welcome to this month's live and ticking on regenerative medicine. I'm Fearghal McKinney, head of BHF NI. Regenerative medicine is at the frontier of research and could one day find a cure for people living with heart failure. Every day, around 64 million people worldwide live with heart failure. It's a condition where a person's heart is unable to pump blood around their body efficiently due to changes to the muscle of the heart. It's often a long-term consequence of damage caused by a heart attack, which means that as heart attack survival rates have improved, more people have gone on to develop heart failure. In its severest form, heart failure has a survival rate that's worse than many cancers and can be so debilitating that everyday tasks like climbing a flight of stairs become a struggle. The BHF are funding research in this cutting-edge field of regenerative medicine. We want to support researchers to push the boundaries of medicine by finding ways to teach the heart to repair itself. Unlocking those secrets could help heal hearts and transform the outcomes for people living with heart failure. The BHF is also the official charity of the year for the 2022 TCS London Marathon, and all money raised from runners will go into regenerative medicine. You can visit our website to learn more, as well as support Professor Sanjay Sinha. Professor Sanjay works in the field of regenerative medicine and is also running the marathon to help fund his own research. And we're calling our support for him is under the banner of Go Sanjay. We have a fantastic lineup of speakers for this event where you can hear more about this exciting area of research. First, we'll be joined by our case study, Vicky Small, who will be discussing her experience of living with heart failure. We'll then be joined by our guest researcher, Professor Paul Riley. He'll be discussing his team's work. Learning how to regenerate the heart after a heart attack was once considered science fiction. Paul and his team are turning heart regeneration into a reality. As many of you will know, during the hour, you can post your questions in the Q&A function, and we try to answer as many as possible after our talks. So if you don't get around to answering your question, you can also speak to one of our cardiac nurses by visiting our Heart Helpline website. You can also join our Health Unlocked community forum for support. This forum provides a safe space to discuss living with any heart or circulatory diseases. Finally, before we move on to our speakers, I'd like to ask you a quick poll question. We do this in all of our live and tickings. And how would you rate your understanding of regenerative medicine? So if you rate 1, poor or little, and 5 is a lot. And we'll shortly bring you the result of that. So let me introduce you now to our first speaker, Vicky Small. Great to see you, Vicky. Vicky will be talking to Ruth, one of our heart story team. I'll hand over to both of you now. Thank you very much.
Thanks very much, Fearghal. Vicky, thank you so much for making the time. I know you give us a lot of your time and we really appreciate it. Now, I know your story really well because I've known you for a number of years now, but for those who don't, which is most people here, can you just very briefly describe your journey to being diagnosed with heart failure?
So I was born with a hole in the heart. We thought that was going to be okay, and it kind of healed up when I was about 12, 13. Then at 15, my mitral valve just suddenly collapsed, so I needed open heart surgery at 16. But the damage caused during the time between the valve collapsing and the operation has caused quite a lot of damage. It's made it really, really enlarged. So I've had various procedures over the year. I've had 2 valve repairs and probably between 30 and 40 cardioversions, because I keep going into atrial fibrillation, which is permanent now, and a few other procedures as well. So yeah, that's kind of the short version, really.
Very, very beautifully and succinctly described. So you were just 38 when you were given the bombshell was dropped to you that you had heart failure, the prime of one's life. It's probably a silly question, but can you put into words what that feels like? You're in the prime of your life, 38, you've got a career, you're looking forward to life, and you're told basically your heart's failing you.
I mean, it's a double-edged sword, really, because in one respect, I kind of felt relieved because I'd been feeling really poorly for quite some time and just couldn't understand why. So when I got the diagnosis, it made sense. But on the other hand, it's had to stop working. Obviously having a family, that was pretty much out the window, and that's been confirmed now. That's a definite no-no. Socializing, going out with friends, that's all really, really dwindled away. And if I do go out with friends and do anything, it can take me days, or sometimes, depending what it is, weeks to recover. And just simple things like wanting to go shopping and getting food, it's just really, really tiresome. Just the simple things like getting up, having a shower, brushing your teeth, all the simple things that most people take for granted every day just aren't you can't take them for granted.
So you've already kind of answered part of this brilliantly, but can you just give us a glimpse into a day in your life of, some of the biggest challenges that you deal with?
I mean, every day is different, but some days, there's a lot of days that are the same. It's just waking up in the morning. Firstly, I'd like to just, say that just waking up is a privilege, because not everybody gets to do that. And, just waking up each morning, I feel really happy that I've got to do that again. But then I have to sort of think, well, have I got enough energy to make myself some breakfast? I'm going to take my medication. Sometimes that can make me feel a bit unwell. So then I have to think, well, am I going to be able to have a shower? Any plans? I then have to think, if I have made any plans, am I going to have to cancel them today? Or can I go ahead and do that? But yeah, a lot of the time I'm just so tired and exhausted, and the medications are fantastic and I wouldn't be here without them, but they can make you feel a bit sort of groggy sometimes as well. So it's, it's a lesser of two evils in some ways.
So it's difficult to plan things long term, I guess, although I know you do a brilliant job in that. You've just got yourself a fully kitted out camper van, which I'm very envious of. But I guess that's one of the things that we all take for granted, is being able to plan a holiday or plan a weekend away with the girls or boys. And
yeah, well, this has been planned. My little adventure that I had last week's been planned for some time, and it was actually supposed to happen before COVID. Then I had a problem with the car, and it's just been ongoing. So I went up to visit some family, and that's been really, really nice. But it's absolutely wiped me out. So I've got like nothing planned for the next few days, just to make sure. So if I do something, just have to make sure I have nothing planned for a week, maybe two. And then if I am sort of feeling okay, then I can sort of, maybe phone a friend and say, I'm feeling okay today, what are you up to? But a lot of the time, most of my friends work as well. So that can make things a bit more tricky.
We've spoken a lot about the facts in the past and how frustrating it is, and psychologically, quite damaging, that heart failure is and a lot of heart conditions are invisible. So unlike other chronic illnesses, you look fantastic. You look like you've just had a 4-hour makeover and you just stepped off a catwalk. But so is that, and so to the untrained people who wouldn't know, if I'd met you for the first time and you told me that you had this condition, I'd say, no, you haven't. So how difficult is that to cope with? And have there been times when you've got quite angry with people and their reactions and their kind of ignorance?
Yeah, I mean, a lot of the time, if I say to people that I need a heart transplant, they say, oh, have you got the operation? Have you got a date for it? They just don't understand the whole aspect of it. And I'm more than happy to explain things and, make people aware of how complicated it is, especially with organ donation. But yeah, it is just really, really difficult sometimes. I mean, in one respect, I'm really glad that I don't look ill. But in another respect, sometimes I just wish people would sort of understand, especially when they're trying to hurry me up or, make me do something quickly. And, I feel like I'm going to faint sometimes. I feel dizzy, I feel hot, I feel tired. Just generally just trying to walk out and about, maybe in town, going around the shops. But yeah, sometimes people don't understand, especially with an invisible illness.
So one of the things that shocked me was when you told me, because I know that you used to like going to car shows in your pimped up car, and that, clearly you have, obviously you have need of a disabled badge, and that you got quite a lot of quite aggressive abuse.
Oh, I've had some terrible abuse. So I was diagnosed 10 years ago, and at the time, and I've still got it now, I'm really into modified cars. So I've got a classic Subaru Impreza, and it's all stickered up, and you know, it's very bold and loud. And parking in disabled bays, I've had so much abuse. I mean, I've had people come in banging on my window, even with my badge in the window. They've been banging on my window saying, is your badge real? Have you, you know, is it fake? Is it really yours? You shouldn't be parked here. I've been shouted at. It's just been awful. You know, I've had 10 years of it, and each time I've stayed calm and I've explained, and some people have been brilliant, and they've apologized and they've said thank you for, you know, educating me on, you know, heart disease, your condition, and they've apologized. I've had some really nice chats with people, but some just don't want to know. And I don't know whether that's because they feel embarrassed about the way that they've behaved.
I hope so.
Yeah, I hope so. But sometimes I do wonder whether they literally don't believe me, and they think because I look the way that I do that, you know, there couldn't possibly be anything wrong with me.
Yeah, no, just sort of, it really sticks with me when you've spoken about that, because it's one of those extra burdens of the condition that you wouldn't realise unless you know somebody who's got the condition. So moving on to BHF research, I know I've already mentioned you've been a brilliant supporter of ours for many years now, but what does hope look like, especially in the form of, you know, research that's being carried out by Professor Riley? What is it? Does that provide a kind of beacon of hope for you? Because as you mentioned, you know, at the moment, ultimately your only hope, it will be a heart transplant.
Yeah, I think hope is more of a feeling, and it's a feeling that one day you might be able to go back to having what you had before. You know, for me, I think obviously having a family, it's too late for me to have a family now, even if there was something that could help, even if I did have a transplant. But being able to get back to work, being able to go back out with my friends, being able to just, you know, not have to worry about planning, but then having to cancel plans, and it would just be amazing, not just for me, but for people like me. And having a heart transplant is a really big thing, and it would be amazing if there was something for people like me in limbo in between. And the only way that that's ever going to happen is if the research carries on with the British Heart Foundation. And without the British Heart Foundation, I mean, I wouldn't be here today. This has been ongoing for over 30 years for me, you know, so it's just brilliant. And I just want them to carry on doing what they're doing. Everybody that's involved, from people, you know, donating some money or buying something in the charity shop, to everybody at the top, just keep doing what you're doing.
Well, again, you've brilliantly partly answered my final question, which was going to be, what would you say to the collective research community, including people like Professor Riley and his colleagues who are working so hard to help improve outcomes for people like yourself? What would your message be? Don't hold back.
Yeah, no, just carry on doing what you're doing. I mean, I absolutely massively appreciate it, and it is a matter of life and death, but it's also a matter of, you know, not just sitting and wallowing and having quality of life. And just please keep doing what you're doing. Don't ever give up. And if there's just that one little thing that you think, oh, this could lead to something else, just keep going down that path, or going down every path, that, because you never know what could happen. And, you know, it really does make a difference.
Brilliant. I've got nothing left to say after that, so I think we'll end it there. Thank you so much, Vicky. Thank you for sharing, as always.
Thank you very much, Ruth, and thanks very much, Vicky. Like Ruth, I'm a bit jealous of the camper van, Vicky, but we're doubly appreciative of you being so honest and open, especially after you've just travelled back from your journey, and, you know, against the backdrop of you saying you needed to take, you know, rest and recuperation after that. So to come on here today and chat to us in the very honest way that you have done is really appreciated. And you look really well. I think that's the other thing. And I had a privilege of meeting you in Oxford last year, and you know, your story is one of, you know, extreme pressure on you and angst, but you present yourself in such a positive way. Thank you very much indeed. So the research that we've been talking about, of course, would often have been considered science fiction, but Paul Riley and his team are helping to turn that into reality. Paul.
Thank you, Fearghal. Is that coming up as a single screen now? You can see that.
It is, yeah.
Great, thank you. So thank you to Fearghal for the intro. Thanks very much to Vicky, as ever, for putting this all into perspective and giving us the inspiration to keep moving forwards, and to the BHF for the opportunity. And really, it's my role today just to give you a little bit of an insight into some of the work that we're doing and the reasons why we're doing it. And I start off with this slide simply because I'm based in the University of Oxford, and this gives you some startling sort of statistics of the number of deaths from heart disease, of which heart attack and heart failure are a major contributor. And it's really the population of Oxford annually. And obviously this is a huge impact from a UK perspective, and the BHF are fighting to tackle this and save lives. If you have a heart attack as a human, and in fact as an adult mammal, you lose a vast number of heart muscle cells. In the human heart, you can lose up to 25% of your muscle, which is around about 1 billion heart muscle cells. And you move from healthy tissue, as shown here in this section on the right of the screen, to scarred tissue, as shown below. And there is really, this scarring is non-functional. And what happens is the survived heart muscle cells just get larger in an attempt to compensate for the loss of the muscle. The contractile, sort of how the heart pumps and the contraction of the heart is adversely affected. And there is no means to replace all of these lost muscle cells currently. And the risk then, of course, is a progression to a second heart attack, or indeed progression to heart failure over time. And the only real cure, as Vicky alluded to, is a heart transplantation. So there is a real need for other strategies and other treatments and cures in this space. This slide is really something for the audience to think about, to participate in. So what I'm going to do here is play you some magnetic resonance imaging scans of a human heart. What you're looking at here are the 4 chambers of the heart, the left and right ventricle and the atrium up top. And here's the septum between the 2 ventricles. And one of these hearts has heart failure, and one of them is completely normal. And I guess I'll just pause for a brief moment. If you want to put in an A or a B sign against which you think might be the normal heart, let's put it that way. Which of the 2 is normal? Is it A or is it B? If you want to sort of have a mental reflection on that, or whether you want to put something down in the chat, that'd be quite interesting to see. So I'll just pause for a second while you give that some thought. But if you look carefully at the images, and then I'll reveal which one of the 2 actually has heart failure. So for all those that thought B, congratulations, you're correct. And just to sort of tell you why and the sort of symptoms of the heart, one is the wall is much thinner, and the heart is very dilated. And you can see that the division between the 2 ventricles is much thinner as well. And with each heartbeat and each heart cycle, this heart number B, or letter B, is unable to pump out as much blood. So the heart is struggling to perform. It's quite expanded, dilated, and the wall, the muscle wall that provides the contractile pump function is much thinner. And the BHF have recognized the need to really try and push treatments in this area and to try and push the research. And in fact, in the 2030 strategy document, mending broken hearts features quite prominently. And this is very, very important moving forwards. And just to give you an idea of sort of regenerative medicine as we see it from the point of view of the definition, this is from Sidney Brenner, who's a Nobel Prize laureate and actually was an alumnus of Exeter College, Oxford. And Sidney defined regenerative medicine as the process of replacing or regenerating human cells, tissues, or organs to restore or establish normal function. Of course, you can apply that to multiple different tissues or organs. In this case, of course, we're talking about the heart. And I was asked to tell you a little bit about myself, just to give you some background and also to highlight the incredible support the British Heart Foundation have given me over the years. So I did an undergraduate in zoology. I think it's fair to say I wanted to be the next David Attenborough, although there is only one. And of course, that was a lofty aspiration. So I moved into doing a PhD in a more molecular biology focused project at the Institute of Zoology in Regent's Park. So that's borders onto London Zoo, but with University College London as the main affiliated university. I did postdoctoral training in Canada, in Toronto, where I learned about how to knock genes out in various animal models, including mouse models. I briefly came through Oxford, and then I got a position as a non-clinical lecturer at the UCL Institute of Child Health, which of course is linked to Great Ormond Street. And there I started my work on understanding cardiovascular development and congenital heart disease. I moved to Oxford with a British Heart Foundation personal chair as Professor of Regenerative Medicine in 2011. So I've been here for over 10 years, although I still feel like one of the new kids on the block. And I have been very fortunate to be made the inaugural director of the Institute of Developmental and Regenerative Medicine as of 2 years ago, and we formally opened in May of this year, and I'll touch on that at the end of the presentation. And just to say that the BHF has supported me throughout my independent research career, with my dating from my first project grant back in 1999 with the lectureship position, all the way down to significant funding support of the Institute itself, which to the tune of £10 million to support the cardiovascular activity and the cardiovascular floor. And as I say, I study cardiovascular development with the idea to move this into regeneration. And I'll give you a flavour of some of that work. So we are interested in how the heart forms. We believe that understanding how the heart forms will not only enable you to understand the causes of birth defects, in which babies can be born with heart defects, and they're the most common type of birth defect, but we also believe that understanding how cells and tissues form in development will help us understand how to reform the heart with injury. And we study the zebrafish. You can see an embryo of a zebrafish here. This is the head, and the heart is shown here. And you can see a mouse embryo shown on the right. And we extrapolate to organisms that can regenerate their hearts intrinsically, so they don't have to have any kind of interference or drug treatment or any administration of anything else. The adult zebrafish can regenerate its heart and does so within 30 days. It's completely regenerated. And the neonatal mouse, during the first week of life, if the heart is injured, can completely regenerate. So we're very interested to understand how those two animal models can inform how we might think about activating cells and tissues in the adult heart and the adult human heart in particular. So we extrapolate down from developmental models through to regenerative model organisms like the zebrafish and neonatal mouse into more non-regenerative, which includes the adult mouse, but also, of course, includes humans. And the evolutionary conservation, so the conservation of some of the processes, cellular and molecular, between fish to mammals to humans, is very, very important in informing us on how we focus in on key pathways. And when we're thinking about repairing and regenerating the heart, the important points are to restore the lost tissue. So that's both to build new heart muscle, but also new blood vessels to support that muscle, and also to alter the environment. The environment is very inflammatory, and there's a lot of scarring and fibrosis, as I showed in the earlier section about human heart. And this really prevents the integration of new cells and the new tissue. So it's very important that we think about ways to modulate that. And I'm going to give you a very brief vignette of each of these two areas in which the group are working on at the moment. So if we think about new vessels and new heart muscle, and in particular the new heart muscle, this is an area where the zebrafish has been very interesting. So as I refer back to over 10 years ago now, when the BHF turned 50 in 2011, they adopted the Mending Broken Hearts as a major appeal, and they used the zebrafish as to publicize this, given the fish can regenerate its heart. And as I say, if you injure the heart either by resecting away a small piece of the apex of the heart, or actually using a very cold metal probe to damage some of the tissue, this will completely regenerate within a few days. So within about 30 days, or a little bit longer with the cryo injury, in which it takes more like 90 to 100 days. But nevertheless, all the processes required to reform and restore that heart to normal, both appearance and function, take place intrinsically within the zebrafish model. And one of my PhD students, who Chloe, is working on a project in which we have discovered the role of a particular gene called WT1V. We think this is important in defining a layer of cells around the outside of the heart called the epicardium. And these cells around the outside of the heart may well contribute new heart muscle to the regenerating muscle of the zebrafish following injury. And this is slightly novel. Well, it's very novel, but it's slightly unusual in terms of what the current thinking is. The current thinking is, and you can see heart muscle cells shown here in green on this image, is that these cells de-differentiate, round up to become more immature, and then can then divide and create more muscle, so that existing muscle creates more muscle. What we're proposing is that either this gene is required for this process, and it may well be, or in fact, what we're seeing in this image here, where you can see some of the green cells with these pink signal, these nuclei, is that this gene is actually marking cells that have come from this outer layer, shown in the pink spots, down into the green layer. And that would be an important advance because it would determine the potential of the epicardium to form new heart muscle. And then if we think about reducing inflammation and scarring and the conditioning the environment, my group's been at the forefront of looking at the cardiac lymphatic system. So the lymphatic vessels, many of you will know the lymphatic vessels are a drainage system for organs and tissues in the body. They build up a tissue fluid, and they modulate the immune response in that they clear immune cells. And they're also, of course, involved in cancer. And if you know about metastases of cancer occurring at lymph nodes and transition of tumor cells throughout the body. But in the process of heart formation, the lymphatics grow and develop like the coronary blood vessels. And we would demonstrated that following injury, these lymphatic vessels, when it could be expanded to increase the immune cell clearance. So to clear out the immune cells once they've done their job and have actually started to clear up the dead and dying cells and debris after a heart attack, the lymphatic vessels, when expanded and promoted to do so by addition of drugs, in this case, we gave them a growth factor called BHF, expanded the lymphatics, moved more immune cells out, cleared some of the tissue fluid that builds up from the damage after a heart attack, and we got a significantly better outcome in mice. And that is shown here just in this schematic. But importantly, what we're doing now, and this is part of the British Heart Foundation funded Oxbridge Centre of Regenerative Medicine, and also jointly with the other two centres in the country, which is the Imperial-led centre and the Edinburgh-led centre by now Chris Denning and Andrew Baker, respectively. We're moving into a collaboration where we're using a pig heart attack model set up by Raymond Assioni in Bristol. We're adding these key factors that we know can make lymphatic vessels grow, which is in collaboration with Mauro Jacka, who's head of the cardiovascular department at King's. And the idea will be to have proof of principle that in a heart that is the same size as a human heart and physiologically very similar, we can expand these lymphatics and get a better outcome following an induced heart attack. And then just to finish with a couple of slides, just to tell you what we've been involved with heavily and to recognise the British Heart Foundation's support. Over the last 10 years now, actually, from an initial conversation and kind of a conceptual idea about a new institute, this has now come to fruition. The institute is here. I'm sat in my office in the new institute, and I'm sat on the cardiovascular floor funded by the British Heart Foundation. And the idea behind the institute is to combine understanding of developmental biology across the brain, heart, and the immune system, to integrate findings from across those three subject areas, and to both understand normal development, translate this across to understanding birth defects, but also expand that into methods by which we can target cells, restore the embryonic potential in adult cells in damaged tissues, and move towards regenerative medicine, where we hope to develop novel drugs and therapies. And just to say, we're not sitting up here in isolation. We're on the Old Road campus at Oxford, and there are a number of neighbouring institutes in which we work with, the Big Data Institute, Target Discovery Institute, to name a couple, and in particular the Kennedy Institute of Rheumatology and Inflammation, where there are expert immunologists and expert in advanced bioimaging, which is one of the major areas that we've developed in the new institute, so that we can actually see the process of cell and tissue distribution. And just to show you how this idea of moving from development to regeneration works in practice. So if we think about all of the sort of major areas that we're interested in and from development, shown in this slide in the red circles here, you can see each one of them maps onto an adult-based process that we need to try and understand. So for example, We might want to understand how coronary vessels develop in the heart and how they form. We equally want to know how we can make coronary vessels expand and grow new vessels in the injured adult heart after heart attack. Similarly, we know that there are immune cells in the heart during development. We may want to know then, can we get some insights into how these cells behave in development, and how can we think about moving the right kind of cell types around in the heart, transitioning out of the heart and retaining the important ones for immunomodulation, and other aspects you can read here on the slide. And just to say, we have the zebrafish, the cavefish model is extremely interesting. I'll be happy to talk about that in questions. Mouse models and of course human models. And as I say, we outsource work at large preclinical models like the pig to colleagues in Bristol. And really just remains for me to thank everybody concerned. I think we have to thank people like Vicky and the patient groups and the people who are out there campaigning on behalf of the British Heart Foundation. The Mending Broken Hearts initiative has been a fantastic initiative that translates right across through into the 2030 strategy. And I'm delighted to hear that the BHF are the main sponsor and the main charity of the London Marathon, and that Regenerative Medicine will benefit from that. Of course, colleagues at Oxford University, and then groupings that have made the Institute of Developmental Regeneration possible, and in particular, Dr. Tetsuya Nakamura and the IMS team for a very generous single donation, which matched that of the British Heart Foundation. And I'll stop there. Thank you very much.
Well, thank you very much indeed for your comprehensive presentation. Again, thank you to you, Vicky. You've been posting your questions in the Q&A box. Remember, you can upvote these, and some of you have been already doing that. So just kick off for one for you, Vicky. And the questioner thanks you for sharing your experience, and just asking, do you belong to any support group for patients with heart failure?
I do. I am on a Facebook group, I think, called Heart Transplant Families UK, and there's another heart failure group I'm on as well. I can't think of it, the full name of it off the top of my head, but they're really useful. They've obviously got a lot of other patients and people with similar experiences, but I think they've got some more professional people as well that can sometimes offer advice. So they're really good support as well, especially in the early years of my diagnosis. I found it quite a struggle, especially with things like sleep and things like that. So they were really, really useful and always gave really good advice.
Just extending the question, is that a scheduled sort of advice, or can you reach out to them in moments of crisis?
No, you can reach out to them at any time, and there's always, because they're quite big groups, they've got a lot of people on there, so there will be somebody that's either been through the experience or somebody else that's struggling with the same thing that can then say, I'm struggling with this as well, so you know, I could also have some help. And there are some people that are like heart failure nurses and things on there as well.
Okay, Vicky, thank you. The next most popular question for you, Paul: will these methods for regeneration apply to cardiomyopathies, i.e. ARVC, and the replacement of healthy heart muscle cells with fibrosis?
Yeah, I mean, I think that it's quite possible that we could apply them to those where there's been lost tissue and fibrosis. I mean, we're trying to look at ways to modulate fibrosis, really targeting the immune system to do that, because the immune system and the actual scarring fibrosis are intimately linked. I think from a point of view of the cardiomyopathy, it's worth flagging the Cure Heart initiative, which of course is part of the BHF's Big Beat challenge, which was awarded to Hugh Watkins and colleagues here in Oxford, but also reaching out to colleagues in the US. And I think that that they have got a different strategy for targeting structural heart disease, cardiomyopathies, etc., which I'm extremely excited about. The way they're going to approach that. So perhaps less of a regenerative setting, but more of a correction for the genetic defects that underpin that disease. So we're really focused at the moment on restoring tissue after heart attack, because that's a major target and obviously very prevalent. And of course, what we really want to do is to prevent people from developing heart failure, as Vicky so eloquently described. It's such a debilitating disease. So that's really where our main focus is, but there is no reason why any disease with fibrosis in which there's a requirement for replacing that with tissue, these approaches couldn't apply to.
Another question from an anonymous attendee: How common? I think we touched on this in the introductory remarks, but I suppose maybe they want to drill down a bit. How common is heart failure after suffering a heart attack?
Well, that's interesting. I mean, I think that, you know, if you have a sort of group of patients that have a heart attack, that 30% of them will walk away from the cath lab having had restoration of blood flow, etc., and that initial intervention. 30% may develop some complication, but that could recover quite well with the current drugs. And then another 30% or so will go on to develop heart failure. So it splits up into thirds. So, you know, and you mentioned the numbers worldwide, you know, Fearghal, in your introduction. It's a very, very prevalent disease. And of course, there are even more than one variant of it, where there's one with a reduced ability to pump blood and there's one with a preserved ability, equally both debilitating, and they move. So that's challenging around the functional readout of the disease, but it is incredibly common at the level of, you know, worldwide cases. But 30% of those that have a heart attack will probably move into a heart failure condition. So it's very damaging. And if you think that, you know, there's a heart attack kind of one person has a heart attack every 6 minutes or so in the UK, it just gives you an idea of the scale of the disease.
Okay. Kind of two questions here, drilling down into some of the methodology. One is Zebrafish a good model to compare with what happens in human cells? The person refers to this as cavefish. I assume that's Zebrafish. Can you say more about the Zebrafish and why it's exciting for regenerative medicine? I'm just drilling down again.
Yeah, I mean, the Zebrafish is really interesting because there are over 80% of disease-causing genes in humans are represented in the Zebrafish. So there's a high degree of conservation of the genetic programs that drive the cell types. All of the relevant cell types are there in the Zebrafish heart, even though it only has one ventricle, one atrium, because it doesn't have a lung circulation, of course, so they don't breathe air in that sense. So it has a simplified heart. But the fact that, you know, if we injure that heart, it regenerates completely, then understanding all the cellular processes and the drivers of that, the molecular drivers, mean that can give us real insights, because those genes will be conserved in human hearts, but just not active. And what we're trying to work out are which are the most important pathways, which are the most important cells to reactivate, and which of those can we target potentially in human models, including human cells and maybe primary tissue biopsies and that sort of thing. But if you like, the middle ground for that is to move that into a mammalian model, such as the adult mouse, which is not regenerative either, and test that fish to mammalian conservation around pathways. So the Zebrafish is a great model system for us in terms of understanding how to target, what to target, and how the fish does it. And we've kind of lost that ability to do it, or they've evolved something separately from us, but they should be conserved.
Okay, thank you, Paul. I'm going to return to you with another couple of questions, but I'm going to go on the voting system next. So this one's for Vicky. Vicky, what advice would you give to someone recently diagnosed with heart failure?
First thing I would say is don't panic and listen to your cardiologist. And if you've got any questions, just write them all down and ask anything, because, you know, they're not going to, don't think any question is too silly, because it's not. And you should also have a heart failure nurse, and they're normally there to phone up as and when you need them. So, you know, always ask lots and lots of questions. And I've also always said to ask about any trials on new medications, anything like that, if it's a possibility of trying. Just ask lots and lots of questions. Don't just sort of sit back and just wait for things. Get kind of proactive, try and learn about your condition as well, and speak to others if you can that have got similar or the same condition.
Okay, and just a bit of an extension on that. Do people respond? It's a difficult sort of question to answer. I'm not being critical in this, but have consultants got the time to do that, or are there other ways of making sure you get the best advice?
Yeah, I mean, I do it when you've got your appointments.
Yeah.
I mean, if I've been really worried about something, I phoned my cardiologist secretary and then just asked, like, if I've been feeling more unwell, and I didn't really sort of know whether my GP would be able to deal with it.
Yeah.
But also don't underestimate the power of your GP as well, because they are really fantastic. But yeah, just lots of questions. But also with the heart failure nurse, they're there during sort of 9 to 5 to be able to ask questions as well if you can't get through to your cardiologist, so you don't want to bother your cardiologist.
Okay. And of course, it just would be remiss of me not to say, but there's lots of information on the BHF website as well, which you can access if you need to. Paul, this is two questions but touching on the same thing. So it's a kind of an expectation of results, and when can we see type thing. But can we expect clinical work on patients to take place, and will I be able to volunteer for this work? An important question. And do we have rough time frames, says another questioner, around when we could expect to see these therapies go through clinical trials or available to the public?
Yeah, I mean, these are all obviously really relevant, pertinent questions and important questions. So there are a couple of things that, you know, make me optimistic about where we're heading. And one of those is when we're looking to reactivate the cell types that we're interested in to restore tissue in the heart, we are using screens that involve known drugs. So drugs that are already being used for a different disease indication or a different illness. And that's helpful because, and there are vast libraries of these, of course, for the many different conditions that are out there, because they then don't have to go through this kind of safety toxicology kind of management, which is a big component of any trial leading into humans. And so really what we're just looking for is efficacy. Do they work in this particular setting? And if we repurpose them for that, then will they work? So that brings everything forward, and it brings everything forward by to the tune of kind of 5 years or so, depending on the scheme of things. So I think we're, you know, the line we usually try and suggest is that it's kind of about, it takes about a decade for, you know, a kind of basic discovery that's got promise to move into that window to then become an actual therapy. And of course, many of them fail, and they fail during clinical trials, as the trials should be designed to ensure that the drug is going to work, and it's going to work safely, and that there is a really good risk to benefit profile in favor of cost of benefit. So, you know, we're confident that sort of in a sort of more 5 to 10 years time, we can start to get into clinical trials and some of the things that we've been describing and discovering. I mentioned the pig study. That's a preclinical large animal. So the proof of principle that if we promote lymphangiogenicis, we'll get a better outcome in that model. That helps us because that's moved it into something much more akin to the pipeline to move in towards humans. So that sort of proof of principle will be very, very interesting to see if that works. And of course, the jury's out at the moment. But kind of a long answer to say that we often say a conservative decade, but I'd be more confident about bringing that forward because of repurposing known drugs, in particular screens, when we're looking at indications at that level, and also because we're already moving into what we call preclinical large animal studies.
And maybe just an extension on that question. Do you get frustrated at the timescales or excited at the timescales?
I get frustrated at two things. One is the timescale for sure, and the money involved, right? So the money involved, I mean, if you want to set up clinical trials, it's vast sums of money, and it requires a huge kind of collaborative team to obviously patient recruitment down to clinical input, down to the basic science, etc. And, you know, it's extremely difficult to manage all of that. But more optimistic of late, of course, because the Oxford vaccine trials for COVID, the AstraZeneca partnership, revealed a very rapid turnaround in the way that trials were carried out. And the idea of doing sequential versus parallel trials and actually being able to publish the data very quickly, I guess the regulators got on board rapidly and in response to the kind of pandemic, and we hope that's changed the landscape actually, and that will push and bring these things into a shorter time frame. Because yeah, the time frame is frustrating. The money and the requirement for money is obviously frustrating because it does take vast sums, and to some extent you kind of have to you have to partner with biotech and pharma to really push the clinical trial element, which is where the most successful trials have come from. So yeah, it's challenging, but I think that the response to COVID and an example being the Oxford AstraZeneca vaccine program was a real sort of benchmark for how this can be done in a much more rapid turnaround time. So really amazing that the regulators got on board in the way they did.
Yeah, I think you told this story, maybe you could share it. The guys who were involved in the COVID vaccine talked about how they managed to do it very quickly, but that against the backdrop of the extent to which they've been doing this for 20 years.
Yeah.
Yeah. Can I just go to a specific, I have no knowledge in this particular area, but there's one specific here, Paul. What do current drugs like losartan do for regeneration after MI?
Like losartan?
Yes.
I mean, I think that there's immune modulators and other drugs out there that are kind of, looking to sort of basically maintain the status quo. They're not regenerating tissue as such. And that's the key things. There are lots of the treatments and drugs that we have currently, the ACE inhibitors, beta blockers, etc., and the anti-clotting agents, etc., are all there to sort of maintain a status quo and help the heart function with the injury. They're not designed to actually restore the injury, which is the most kind of important component of actually getting a regenerative response and preventing that decline over time. So lots of different drugs that are currently out there are really designed along those lines. And some of the big immune modulators that have been used have been moderately successful, but they tend to be rather too blunt in terms of they tend to target the immune system more globally and harshly. And if you do that, you realize you need the immune system to help clear up the process. But what we don't want is for it to persist and become chronic and continue that inflammatory response. So you have to modulate it. You can't just wipe it out completely. And that's where people are heading now in that particular area of trying to manage the immune response and dampen it down a little bit, retaining it, the good activity, if you like, and getting rid of the kind of chronic bad activity.
There are a couple of specific ones here, Paul, and I'm wondering whether we should leave some of those to be answered separately. But let me go to a wider one just now. What do you think will be the next big milestone in regen medicine?
Well, I mean, there's some great work going on, of course, all over the world in this area. And in terms of cardiovascular regenerative medicine, there are kind of a couple of things that I'm really intrigued about. I'm intrigued at the targeting of heart muscle cells to re-enter the cell cycle, divide, create more heart muscle. And there's been some fantastic studies. I mentioned Maro Jacka at King's College London. Maro did a pig study with a microRNA that drove heart muscle division and proliferation and restored vast amounts of muscle in that study. The issue there is that those pigs died of sudden arrhythmic events, so the heart became arrhythmic. And part of the problem, and this is the challenge, but it's an exciting challenge, is to get those heart muscle cells that are divided and then kind of like redifferentiated to become mature enough to electrically couple properly, so that the electric activity of the heart is synchronous, there isn't this arrhythmic event, and then animals, of course, suffer from that. But that's a good challenge to have, and the idea of using factors to mature those cells quickly is something that's emerging as we speak. So that's a really exciting area. The other exciting area, I think, is engineering CAR T cells to modulate the immune response after injury. One of the contributing factors to heart failure being such a devastating disease is actually autoimmunity, where the damage to the heart releases proteins that the body, believe it or not, hasn't seen before in terms of the immune system education. And then those are trafficked to influence immune cells to become hyperactivated. They cycle back to the heart and cause more damage. So understanding how to engineer immune cells to be able to recognize some of those proteins that are released upon injury is a very important component, as is the idea of moving these cells around, as we're doing with the lymphatics, that might influence the ability of those cells to become hyperactivated and mount a autoimmune response. So I'm really excited by the new muscle end and restoring muscle and how that might go about, and it's moved into large animals, and very excited about the kind of immune modulation, engineering the immune system to enable the environment for not causing more damage, but B, allowing that new muscle and those other tissues to be retained over a long-term period.
Okay. Next question. Once a breakthrough has been made, do we know how the procedure of regenerating scar tissue would work? Would this be in the form of medication?
Yeah, I mean, that's a really good question. I think so. Clinically, the ideal scenario, of course, would be to take a pill, you know, an oral dose, because it's less invasive and so on. But there is an opportunity. There's a therapeutic opportunity. For example, when you have a heart attack, there's a sort of 2-hour window at which the patient would be quickly brought into the cath lab, and a cardiologist would open up the artery for reperfusion to allow the blood to restore, perhaps fit a stent to make sure the artery remains open and doesn't block again. And during that period, you have an opportunity to administer treatments directly into the heart, either through the vasculature or even directly into the muscle. So there is an opportunity there, I think, for treatment. Of course, you don't want it to be too invasive, and so it would have to be a fairly stable long-term treatment at that time. You wouldn't really want to be coming in to have, you know, injections or catheter-based infusions of drug. The other way that treatment can be brought about is, as they call, drug-eluting stents. If you put a stent in to open up an artery, it's just usually a little metal coil device that will open the artery up. Then people have loaded up that metal and that surface with a drug that can be eluted over time. So there's an opportunity there as well. So I think from a clinical perspective, if we're not going to get to the magic bullet, which is an oral pill that will reactivate and restore and target specifically just the cells in the heart and not cells elsewhere in the body, then it's likely that an intervention could happen during that kind of 2-hour window where that primary intervention is required to open up the blood vessels again.
Thanks, Paul. Just, I think, one final one here. What would be the top 3, you probably alluded to it, top 3 breakthroughs needed to help you make a huge progress or advance, say, in the next 10, 20, 30 years?
Yeah, well, I think we need, I mean, the use of the word 3 is actually quite prophetic in a way, because I think we do need 3 aspects. And with that, we need a combined therapy approach. So if you just make new heart muscle through some of the methods I was mentioning, and that's not vascularized, and it doesn't integrate properly with the survived muscle, then you've got arrhythmia and you've got a graft of new muscle that won't survive because it needs blood and it needs oxygen, etc. If you, so with that in mind, you need to make new coronary blood vessels. You need to be able to push the blood vasculature to support that new muscle that's forming through whatever procedure and process you've driven. And then, as I've been saying throughout, you also need to modulate the immune system and alter the fibrosis that occurs immediately after the event and ensues, because that fibrosis is non-functional and that scar tends to be very stable and very difficult to alter and actually restore tissue on that background. So I think those are the 3 things we need. You need to immunomodulate to reduce scarring in the immune system. You need new blood vessels, and you need new heart muscle. And these 3 areas actually fall into the camp of the British Heart Foundation Regenerative Medicine Centres. Each centre is tackling these individually, but also collectively and collaboratively. So I think the 3 centres, with the BHF support, are in a very good position actually to do a combined therapy approach, targeting each one of these in combination in a large, for example, animal model, moving toward clinical trials. So that's where we really need to be.
Very much, Paul. And in fact, that answer has already also answered another question where somebody was asking, or is this all part of a jigsaw and people working together? And I think there's considerable working together there. Vicky, thanks very much. Have you learned anything new today, Vicky? I
have. I mean, I find it really interesting anyway, but yes, every day's a school day, as they say.
It's a school day, absolutely. Absolutely. Paul, just before you go, I was really struck by the way you described how you put together the centre in Oxford, and this was a vision, and I just loved the idea that, you know, where you get 2 people and you get an idea and it develops from that. And so imagine the future and make it happen. Briefly, just tell us that little story.
Yeah, no, thanks, Fearghal. It was, well, it's been a labour of love for a long time. And, you know, myself and my very close friend and colleague, Professor George Hollander, who's a paediatrician by training, works on development and works on the development of the immune system. we sat down in Jesus College in Oxford, and we had a conversation for the first time. And he mentioned an idea about bringing forth the Institute of Developmental Medicine. I just landed from the Institute of Child Health at Great Ormond Street, and I was a bit disparaging because I sort of said, well, you know, the Institute of Child Health is going to be a tough act to follow and to compete with, because they've got Great Ormond Street on their doorstep, which means they've got the clinical interface and they've got the samples, etc. But, you know, we thought about it, and then we sort of went away and said, but why don't we bring in the regenerative medicine component? Because that's what we're working on, either individually or in groups that we were aware of in the country or around the world, you know, sort of heading in this direction. So why don't we bolt those two things together and integrate them? And then when we approached the British Heart Foundation, and that was done by Professor Sir John Bell, our Regent Professor of Medicine here, approached Peter Weisberg in the first instance as the then medical director. They thought this was a great idea and a potential to put a flagship institute up, but very astutely realized that it would be better if it integrated more than one discipline. So that if we got, say, neuroscience and immunology involved, then we could have kind of the integration of the two post-mitotic or mature organs like the heart and brain and the central nervous system, and then the immune system kind of integrating both with injury and with the development process. So that's how that kind of went about, and the BHF committed £10 million, as I say, and delivered on that, and delivered excellently over a time frame in which we helped fundraise, and we fundraised with the Oxford Development Office. And from that perspective, it was a real success story, and it was a pleasure to work with all of the various colleagues in the fundraising departments within the BHF. And then we, with that activity, we managed to persuade a very generous donation from a Japanese donor, as I say, Dr. Tetsuya Nakamura, who's head of the IMS group, and he's a practicing cardiologist, but provides healthcare in Japan. And he was really taken with the idea and the concept, and he stepped forward and gave us a very generous gift to the same tune of £10 million. And once we had the money, that was it, we were off. Once you get the attention of the university and the powers that be with the funds, etc., and the strategy around what we were proposing to do, we had incredible support from the university and the medical sciences division. So, and here we are, 10 years later, the building's up. It's now filling up with young people who are really keen to do studies in regenerative medicine, developmental biology, and it's incredibly exciting, and it's a real pleasure to be the director of the institute and to have, you know, this floor, which I'm just staring at BHF logos and red everywhere, and it's terrific.
Thank you very much indeed, Paul, and thank you to Vicky, and thank you to the audience for watching this edition of Live and Ticking. We hope you've enjoyed hearing from all our speakers, and thank you to Ruth too. Before we wrap up, I'd like to ask you another poll question that's related to the first one, obviously. How would you rate your understanding now of regenerative medicine? 1, little, or 5, a lot? So I'll let you vote. And if we haven't managed to answer your question today, then we encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query. And I know there were a couple of specific questions in there that hopefully we can answer at a later date. All our incredible research is funded 100% by you, the public. If you've been inspired by the amazing science you've heard today, then all donations to support our life-saving work are very much appreciated. Our Live and Ticking series are monthly, and we strive to produce the best events possible. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey at the end of this event or through an email you receive in the coming days. This Live and Ticking event was recorded and will be available on our YouTube channel from next week. Our next event will take place on the 26th of October on the topic of risk factors. I hope you can join us then. In the meantime, go Sanjay, and support Sanjay and regenerative medicine in the London Marathon coming up soon. Thank you and goodbye.